The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. We're gathered here for the next episode of TMD Demystified. I am Tony Urbanic. Today's episode is actually number 99 in the series, which started almost 2 years ago, getting ready to do our 100th episode next week. I record these on Tuesdays. I hope to have a surprise for the viewers on our 100th episode. I won't divulge. I'll leave you hanging as to what that might be. But if I can pull this off, I'm looking forward to it. It can take a little technical expertise on my side. I know I can pull off the material. What I don't know is I can pull off the technical things necessary to present it to you in a way in enough time. I have about a week to put it all together. In any case, we'll go on for today. Today's episode is going to be entitled Asking Questions in TMD. Now, I had a previous episode early on. It was actually probably within the first 10 episodes, as far as asking, the title had something to do with asking the right questions or asking the correct questions, asking the right question. At that point in time, what I was trying to get across was asking the right questions to determine what is going on with TMD. What are the questions one would ask to try to figure out what the solution to TMD is? Now, since then, and with my studies and experience, et cetera, we have long figured out, and I've discussed exactly not only the solution, but the method and the material and that has been available for quite some time to put it all together to figure out what's really going on with this thing that we call TMD and why is it so misunderstood? Why are so many, more than hundreds of thousands, it's honest to say, millions of patients, mostly women, certainly within the United States of America and probably beyond, certainly beyond, are going around in circles for 5, 10, 15, 20, 30 years, not getting resolution to their problems, to the symptoms that everyone calls TMJ. So we're going to kind of condense and focus and unpack the specifics in this episode about what the patients and especially the doctors, what questions they should ask when they're contemplating treating or diagnosing TMD. What are the correct questions? So let's first talk about the concept of questions. So in my training, I was taught by my mentor, who was David Hall of Vanderbilt University, Department of Oral and Maxillofacial Surgery, chairman and director, all about critical thinking. Now, critical thinking, I've mentioned it before in other episodes, but it's a simple concept. Critical thinking is learning to ask questions. It's that simple. It isn't the method of manipulation of the material. It's looking at the material and learning to ask the right questions. Now, unfortunately, most patients aren't equipped one way or another, not to sound condescending or critical, but they're just not equipped technically, medically, instructionally to go to critical thinking about their health care or something called TMJ or TMD. They may be very well equipped to think about critical thinking as to the best method to mow their lawn or the best way to get their car repaired. You can apply critical thinking to every aspect of life. But when it comes to healthcare, patients are not equipped well to go into critical thinking because they don't have the nomenclature. They have too many misunderstood words. They're not experienced. There's so much misinformation and nonsense that goes on the internet about aspects of treatment, medical treatment. They're not really equipped about critical thinking, but doctors should be. They are. I mean, you're the expert, whether you like it or not, or you're thought to be the expert, whether you claim to be or not. And you should be well equipped to do critical thinking, which is asking the right questions. That's all critical thinking is. And the patients themselves, although they're not so equipped to actually have the questions, they unfortunately feel anxious or afraid about asking any questions, which should not be the case. Patients should be very well familiar with asking questions of the doctor or the healthcare providers about their healthcare. So we're going to just kind of talk about these concepts a little bit, but I'm going to be very specific. I don't like to talk in generalities. Doesn't take you anywhere. So what questions should doctors and patients ask when contemplating, diagnosing, or treating, or being treated for TMD? Well, we have established with certainty that inflammation within these joints drives the whole problem, drives the whole cascade of events leading to the symptoms. If you didn't have inflammation within the temporomandibular joint, you would not have TMD. It's another way of saying the same thing. Inflammation within the joint drives all the symptoms, and I mean all of the symptoms, and that's been covered greatly and specifically and in detail in many of the other episodes. So we're just going to leave it at that, and we're going to start there. Inflammation within the temporomandibular joints drives the whole process, drives the symptoms. Now, with that as a starting point, as an agreed upon point, if you have the symptoms or you are treating the symptoms, what are the questions one should ask about the treatment itself, either the treatment offered by the provider or the treatment that the patient is offered, and they are trying to decide whether or not they want to do that or not, whether it makes sense. So the real question then starts out both from the doctor and the patient is, does the treatment itself treat or decrease inflammation within the temporomandibular joint? Now, if you can honestly, obviously, and can describe how that occurs, whatever the treatment is will decrease inflammation within the temporomandibular joint, then you're on the right track. And there are several things that can decrease inflammation within a temporomandibular joint. And the first one we've talked about before are nonsteroidals. Nonsteroidals and inflammatories, which will be ibuprofen and aspirin. And I have mentioned in the past Tylenol, and I stand corrected, and I knew that, but Tylenol is not a nonsteroidal. It's a pain medication, acetaminophen. But nonsteroidals or steroids themselves do a really good job of decreasing inflammation within a joint, but only for a short period of time. And we all know by experience, intuitively and heuristically, that you take nonsteroidals for a while and all they end up doing is making your stomach hurt and burn, and they run out of steam as far as decreasing inflammation in any particular part of the body. So they have a value, but only short term. That is a fact. Steroids, we know all of the severe complications and downside of taking steroids. So that's really a non-starter. But the question is then, after you get by the non-steroidals, what else is available? Well, actually, as it turns out, not a whole lot. Once the damage is done and chronic inflammation sets in, there's very little you can do about it other than, again, common sense is to unload the joint. If you have a bad knee, placing the patient on a set of crutches will get the load off the knee, and it will decrease inflammation. And within a relatively short time, with the load off the knee, it won't hurt anymore. And obviously that same thing is the method by using the Urbanic device and protocol, by unloading the joint over a predictable and quantified period of time, will eventually allow the inflammation to die down, and permanently, as long as the protocol is applied. And that is the simplicity of what we've learned, what we've done, what I teach, and how it works. But it continues to be a significant problem in our culture and cultures throughout the world as to how to treat this problem, because it is all kinds of different things that are used that do not decrease the inflammation in the joint. They attempt to treat symptoms, various symptoms of the temporomandibular joint, but it does not treat the actual cause, which is inflammation within the temporomandibular joint. So the question is, whatever is offered, does it actually decrease inflammation? And the patient should not be afraid or anxious, and have the fortitude to speak up and say, doctor, how does this actually decrease inflammation within my joint? Because now I know that inflammation is the source of all the symptoms. Now, the answer that the doctor gives may be various answers, but the doctor himself needs to adhere to ethics and certainly be truthful, but to be honest and be able to explain however that particular treatment is supposed to work. So the most common treatments out there that I've spoken on before is number one, drugs. Okay. Various drugs I have seen used, including narcotics, including muscle relaxants, including, for some reason, antihistamines, which doesn't make any sense, including psychiatric drugs, neuroleptics, and, you can kind of figure out the theory that they have behind that. Muscle relaxants, that muscles get tight, and if you relax the muscle, it doesn't hurt, but they don't even understand where the pain comes from. It doesn't come from the muscle. It comes from where the muscle pulls on the bone and stimulates the nociceptors. And those kinds of explanations are not available to the doctors that offer the treatment. And I hear it all the time. I see it all the time because we see so many patients here. And things have to straighten up. They got to change and address the problem and be able to ask the critical questions of the doctors, and the doctors need to ask themselves, if they offer a treatment, how is this actually supposed to work? So one of the other issues is, does the treatment follow the FDA standards, the FDA protocol? Is it being used on label? A good example of that not applying would be the botulinum toxin A, i.e. Botox or other equivalents. Botulinum toxin used for the treatment of TMD, which is the paralysis of multiple muscles or a muscle segments because the muscle is tight in trismus, is not on label. It's an off-label use of the botulinum toxin. It is not approved by the FDA, not approved. So you're on your own And if you have a complication with that, you're on your own. There is no FDA approval for botulinum toxin using Botox. Now, the thought or theory on botulinum toxin is already mentioned. If you have a masseter muscle and the patient says, well, most of the time it hurts right there, which actually the truth is what they're pointing to is the coronoid process. I'm getting a little off here, but I'm so familiar with this problem. It is a common area for the patient to say it hurts there often. It hurts there in the morning, or it hurts there after I eat, or it hurts there after I try to open my mouth wide. What they're pointing to is the coronoid process. And if the patient has TMD, 99% of the time, if you stick your finger in the mouth and go slide it up along the coronoid process as close as you can to the tip of the coronoid process and push, that is the place it hurts. And what you're doing when you do that is you're pressing on the insertion of the temporalis muscle on the tip of the coronoid process, pulling on the periosteum, stimulating the pain on the nociceptors. That's why the tip of the coronoid actually hurts. But when the patient says it hurts there, frequently it's not the muscle even, it's the coronoid process right there. So, paralysis of that muscle or the temporalis muscle or the sternocleidomastoid on neck pain, it'll paralyze the muscle, no doubt about it. And it will keep the muscle from pulling on the bone, which will decrease the pain. But it's used off-label, and it's only for one particular pain, one particular point, which brings up a point that I've touched on before. I had an actual patient who was an employee of a plastic surgeon who had bad symptoms, huge numbers of years of quote, migraine headaches, which were TMJ headaches, and other symptoms associated with TMD. And she sat in my office because she had access to so much botulinum toxin and had so many injections over a long period of time. She had no facial movement of her facial muscles at all, couldn't even smile. And her skin was just shiny as a cue ball, but still having symptoms, still having other symptoms, still having pain that she described as jaw pain, ear pain. So the point being that that particular treatment has limited ability to affect one particular symptom in one particular location, and even its own use is misdiagnosed or misused sometimes, especially if the patient is pointing to the coronoid process and actually that is where the pain's coming from, so they paralyze the masseter muscle, and that's not going to fix the problem. Another question that the doctor should ask offering treatment and the patient should know enough about is, has this been studied? Are there peer-reviewed studies on this particular treatment? Is there, statistical information regarding this? And, where is it, or how can I read it, or would you make it available to me? Those are honest questions that patients should ask, but doctors using a treatment modality should already have the answers to those available to them so that when they are asked, they can tell the patient the answer. And obviously, for example, being off-label, there are no good studies that show that botulinum toxin actually decreases inflammation within the temporomandibular joint. In fact, there's no studies doing that. All they do is studies, we can paralyze a muscle. So the real question is, are you treating the symptoms or the cause? Are you just treating symptoms or the cause? So to briefly run through again, the symptoms of TMD are frequent or recurring headaches, earaches, jaw pain, neck pain, upper back and shoulder pain, arm, hand, finger tingling and numbness, tinnitus, ringing in the ears, fullness in the ears, which is subjective hearing loss, and vertigo and various kinds of locking. Those are the symptoms. And so if you say you have a treatment for, let's just say locking, there are various kinds of closed locks. where you have a temporary closed lock or you have a permanent closed lock. You have a closed lock that they can only open to 25 millimeters. We had one yesterday of only open to 20 millimeters, which was permanent, could not get beyond 20 millimeters. I had a patient yesterday that had an intermittent closed lock where it was intermittent in that the meniscus would ball up in front, but with enough force or pressure on the condyle, the meniscus would pop back, usually with a lot of noise and some pain. Now, those are very, very common symptoms. We just hear them so often. But the question that the patient should ask is, well, do these exercises that you gave me for this locking, or does this device you have given me to stretch the muscles and stretch the opening, which is the exact opposite of what you should be doing. You should never force any kind of closed lock TMD. But the question that should be asked by both the doctor and the patient is, how does that decrease inflammation within the joint? Well, actually, that particular thing will make it worse. Any force you put on the joint, on an area of chronic inflammation, will actually increase the chronic inflammation. And cement, literally cement the displaced meniscus so that it is less likely to come back rather than more likely to reduce or come back in the proper position. So the real question that should be asked, along the lines of critical thinking, asking the right questions, asking questions to start with, and then asking the right questions, and not being afraid to ask the questions, whether you be a student or whether you be a patient or whether you be the provider doctor, is how does this particular service or device or treatment or drug decrease inflammation within the temporomandibular joint? Because if it does, you're helping out. You're going along the right track. If it doesn't, and you can't honestly say that it does, you're spinning your wheels in mud. Another good example comes to mind is orthodontics. I can't tell you the number of patients that have come in and have been recommended to go through a course of orthodontic treatment, braces, to treat their temporomandibular joint problems. I'm all for orthodontics for straightening your teeth. And over my 46 years of orthognathic surgical treatment, I've worked with hundreds of orthodontists in conjunction with the surgical services I provided to come up with a great result for patients, both facially and dentally and functionally. It's a great service. But orthodontics to treat inflammation within the temporomandibular joint, that's not what orthodontics does. That is not what orthodontics does. But I have had so many patients come in, they have already gone through orthodontics, many of them, and been told that is going to straighten out their temporomandibular joint symptoms and doesn't. Or patients come in for a second opinion or have come in and referred in, and I find out that, well, I've been told by my orthodontist or my general dentist I need orthodontics to straighten this out before they did it. And I said, the real question is, does orthodontics treat inflammation within the temporomandibular joint? And the answer is no, it does not. So, and then the final one, and I've spoken on this routinely and recently also, and that's the one that is used most often, that has absolutely no peer review studies or any particular study of how a night guard will treat inflammation within the temporomandibular joint, although they're given routinely on hundreds of thousands times a year, for certain, thousands of times a day, hundreds of thousands of times a year throughout the United States, with patients who have various kinds of facial, jaw pains considered to be TMJ, TMD, and the dentist will give the patient a night guard and tell them this is treatment, but has absolutely no explanation on how that night guard works. Well, it might have something to do with bruxing. Well, actually, more routinely than not, patients will bring their night guards in and say, this makes it worse when I put this in. And bruxing is the primary cause of chronic inflammation within the joint, but it's not the only cause of chronic inflammation within the joint. So, but a night guard has nothing to do with decreasing inflammation within the temporomandibular joint. It guards, it's a night guard, meaning you wear it at night. If you brux, you can't damage your teeth. You may chew up that night guard, but you can't possibly damage your teeth, and that's a good purpose for it. So if you do brux, night guards are great for keeping you from damaging your teeth, but if you're expecting it to treat TMD, not going to happen. Why? Because it doesn't treat inflammation. Doesn't make inflammation within the temporomandibular joint go down. Frequently, it makes it go up because you just have more able to put more force between your posterior teeth, where 90% of your loads on the joint come from. So you got something between the posterior teeth. You're going to increase the load in the temporomandibular joint rather than decrease the load within the temporomandibular joint. And I went over one here. I missed one, was, and it's common. It's getting more common. I hear about it more commonly in our patients here, dry needling from the physical therapists. And so, you know, there's a theory out there that, you know, stick a needle in a muscle, you know, without injecting anything, just a dry needle into a muscle with trismus, and it will allow the muscle to relax. Well, that's probably true, I guess. I didn't investigate the theory and actually how that works physiologically. The insult of a needle within a muscle, allowing the needle to relax. I probably should take the time to do that, but let's just say it does. I'm not disputing that, and I won't dispute that at all. We did talk earlier about a side effect that I had a patient with. The physical therapist got a little too aggressive and stuck the needle into the top of the lung, causing a pneumothorax, and the patient ended up in the hospital with a chest tube to correct the pneumothorax because of dry needling. So even, you know, dry needling isn't without complications. But the point is, let's just say dry needling does a great job of relaxing the muscles wherever, of the neck, of the shoulders, wherever you want to do the dry needling, but does it actually decrease the inflammation within the temporomandibular joint? So, and most of these patients, almost all of them, come in with certainly more than one symptom. Most of our patients come in with the majority of those 10 symptoms I reeled off. The majority, meaning more than 5. Actually, most of them end up, I can honestly say, with 6 or 7 out of 10. It's more like 7 out of 10 of those symptoms. Most of those patients have those symptoms. And some of them have all 10. It's rare to find a patient who just has one symptom out of those 10 symptoms. That is rare. You know, patients come in and say, oh, I don't have any, you know, you go through the symptom list. No, but they have headaches. This, my only symptom is headaches. That is very rare. Most of them have headaches, that's for sure. Headache is the #1 symptom associated with TMD. Neck pain is the second most common symptom, but is extremely rare for someone to, I can't remember the last time that I had someone come in with just one symptom. So these particular issues or occlusal reconstruction, you know, I won't go into that. That is a series of events that can go on for 3 or 4 years, ending up with a course of orthodontics or total occlusal rehabilitation and 28 crowns and $50,000 of care, and does not address the inflammation within the temporomandibular joint. So I'm trying to get the point across. I hope I've made it. I hope I haven't overdone it. But sometimes it's necessary to be poignant and to be direct about solving a problem that you see, not trying to sugarcoat it too much. I know what I teach, and I know what I found out, and I know what I say upsets some people, although I can't get anybody to at least on these podcasts, on this podcast site, to give me any criticism of what I teach or what I say, and I ask for it. I'd be happy to discuss it with you. I'm open for discussion. I can prove what I say. But the point is, it's about asking the right questions of yourself, of the literature, of what you've been taught, by whom you've been taught it. If a person cannot explain what they're doing and why they're doing it, maybe they shouldn't be doing it. And that applies to everything, whether it be the person fixing your car, or mowing your lawn, or treating your TMJ. And the patients do not need to be afraid of asking questions. A good doctor, although he might be busy, and I've done that. I've been so busy. I wanted to get on with it. I'm guilty. But I definitely want to answer my patients' questions. And if by any means I have the time to give them a solid, respectful, complete answer, I do so, and explain to them in terms that they can understand what and why I'm doing what I'm doing. That applies to everything I've done in the past regarding any kind of maxillofacial reconstructive surgery, but certainly applies to non-surgical TMD. So the doctors need to use critical thinking, which is asking the questions that are just common sense questions. And the patients need to be able to ask questions of the doctors and get a reasonable, understood answer as to how whatever they offer actually works. And it all boils down to, can they explain how that particular procedure, that service, that drug actually decreases inflammation within the joint? And if it does, I'm all for it. And if you have a better way than unloading the temporomandibular joint to decrease inflammation, I want to know about it. I really do. I want to know about it, because I'm all for it if there's a better way than just unloading the joint itself. So for today, I think I'll quit, and I hope this helps. That's my intention, is to do nothing more than help my dental colleagues, help my medical colleagues better understand this problem and diagnose it properly, and help the millions of patients out there who suffer continuously and go around in circles trying to find treatment for this conundrum called TMJ/TMD. For today, I look forward to speaking with you at our next episode, which will be our 100th episode of TMD Demystified on Dental Town. I am Tony Urbanic, and again, this is TMD Demystified.